one, and then we can
All right.
formally begin.
Okay. All right. All right. That's fine. Thanks. Oh, hi, Daniela.
Hi, I'm here.
Thanks for joining.
Yeah, of course, I'm here. Okay.
Good to see you. Ah, Leslie. Hi, Leslie.
How could I not be here, Lily?
Good to see you too. Thanks for coming.
Good to see you. We've got to stop meeting. We're like every 5 minutes we're meeting,
Yes.
which I'm enjoying.
Yes, me too. Definitely. Yeah.
Good afternoon, colleagues, and welcome, and thank you for your patience. I've just allowed for a few extra minutes as people join the call this afternoon. So my name is Bronwyn, and it is my pleasure to welcome you to our third colloquium of the year, but the previous two have been book launches of two professors in our department, Ashraf Kaji and Leslie Swartz. And today really is our first sort of formal colloquium talk, presented to us by Dr. Lily Kpobi, all the way from the University of Ghana. And Lily has a special place in all of our hearts because she has done an MPhil at Stellenbosch and she is a doctoral student as well. Very well published, very exciting research that Lily is involved in. And it really is our pleasure to host you here this afternoon, Lily. So as you can see, Lily currently works as a research fellow at the University of Ghana. She is also a registered and qualified clinical psychologist, and she explores issues around mental health and culture, and has a particular interest in understanding and harnessing Indigenous healthcare resources in order to promote collaborative mental health care. So, Lily, we are very happy to have you here this afternoon. Thank you for taking the time. I must say, I was worried for a minute, thinking, "Oh my word," because we have a 2-hour difference, and I never quite clarified that with you. So I thought, "Oh my word, I hope that it's going to happen at South African time." So thanks so much.
Yeah.
And let me stop sharing my screen. As Lily, will you be sharing a PowerPoint on
Yes.
your side?
Yes, I will.
Okay. So then, colleagues, just in terms of the presentation, so Lily will present to us, and then you're welcome to post your comments in the chat feed as Lily is presenting, and then we will take some questions and comments at the end of her presentation. All right. So thanks very much, Lily, and over to you. So just to check, Lily, I imagine that you shared your screen, because I'm not seeing anything on my side yet. Okay, I think we may have lost Lily for a moment there. So let's just give her a few minutes to connect with us again. So it's nice to see that there are many more people in the talk this afternoon. Thanks very much for being here. And here's Lily again.
Hello?
Hi, Lily, you're back.
Okay. I don't know what happened. I tried to share my screen and then suddenly it kicked me off. I don't know where that came. Let me try again.
Okay. Sorry, Ash is going nuts.
I don't know why it's not allowing me. Okay, there we go. I hope you can see that.
Yes, I can see it. Thanks, Lily.
Okay, let me put that in PowerPoint then. Okay, great. Thank goodness. Let's hope that it doesn't do that again. Okay, hello everybody, and sorry about that little glitch there. It seems like the the internet warriors sometimes just come for us at the wrong time. I'm really excited to be here. Well, there and here as well, back in Stellenbosch. There are so many exciting memories for me there, and I mean so many times when I sat in people presenting at Colloquium. So it's a nice experience to be on the other side of the room this time. I'm going to be talking about some of the work that we've been doing lately here in Ghana, particularly the fact that we've been using visual methods to understand mental health issues here in Ghana, and how we've so far been able to use that for some advocacy work and what can be done with it in the future. So I am going to be talking to you about our project called the Together for Mental Health Project, which we are in the process of wrapping up. So I'll give just a really brief overview of what visual research methods are about, and the focus that we had, and also some of the benefits and limitations of using visual methods more generally. But then I'll dive immediately into the project itself to give us some idea of some of the experiences that we had, some of the challenges and opportunities that we had through using visual research methods, so that then we can look at what we've used it for in terms of advocacy and activities. Okay, so generally speaking, and as I said, this is just a really brief overview because I want to focus more on the presentation and the project itself. But using visual research is simply using different mediums or different media to try and understand and interpret people's experiences. So it isn't necessarily a replacement of traditional qualitative research methods or approaches, but it can be a good addition. It lends a different perspective or a broader view or understanding of the different phenomena or the different experiences that one may be interested in. And so in using visual research methods, you could use photographs and drawings, you can use film or video, graphics, there can be paintings or sculptures, that just other creative and visual things that you can bring on board in your research to add some more depth and to add some layers of meaning to what you are looking at and what you're interested in. Now, the images that you use, the visual things that you use, most of the time can act as either stimuli for the discussions, or they can be the structure within which you view interactions, or within which you approach interactions. And so it can be from it can be led by the participant or led by the researcher, but at the end of the day, it's about a co-production of experiences and of meanings. There are several advantages to using visual methods. It's a useful tool to have, and it can be a very powerful tool to use in understanding research topics of interest, because it crosses barriers. If you do not speak the same language, but you see a photograph, it can mean something to you. It even crosses race and class and issues of disability. The reality is that not everything can be said and spoken about appropriately or adequately using words. And so using visual methods adds another layer, an additional layer of meaning and interpretation to the things that go on around us, which we may be interested in. But very importantly, sometimes it is easy for certain groups of people or certain experiences to be invisibilized. That's always a difficult word for me to say. People can feel as though they are not seen, their efforts are not seen, or their experiences and their pain is not seen. But when you show it visually, when you can capture those experiences or viewpoints on film or in photographs or in drawings, it allows those who are normally invisible to be seen. And those kinds of experiences or those kinds of activities, they have a very unique transformational ability, because they evoke certain emotions. They promote self-reflection and an engagement with the data, which may not be quite the same when you have to read snippets of, let's say, interviews or group discussions and things like that. So it's more engaging of your audience or the people who are reading the work, and then it allows you to reflect on what it is that is being discussed or is being elicited. Those kinds of experiences are also very empowering for both the researcher and the participants, particularly when the processes involve a co-production of the meaning. When you're working together with participants to help them to understand, for them to help you understand what they've experienced and what they're going through, or what something means to them. That process of reflection, of sharing, of explaining is quite empowering, and it removes the veil, so to speak, of sometimes issues that are not spoken about in certain circles. So if you think about mental health in many African countries, it is highly stigmatized. It's not really talked about. But if you co-produce videos and help people to show their reality and show that they're human just like the rest of us, it is a very empowering experience that can help them also. And as a researcher, being part of that journey of recovery, of discovery, of understanding what people go through is very empowering for you as well as a researcher. So this brings it results in a power shift, so to speak, between the researcher determining the pace or determining what they want to look at, and can give a certain level of control to the participants as well, because they determine what they want to show and how they want to show it. And so all of these things will enhance the kind of data that you are able to collect. There'll be multiple layers of meaning that can be created. You create relationships and you create knowledge, because you're engaging with people within their space, within their creative ideas, and allowing them to set the pace, but you are learning along as you go with them. And then finally, visual research, it helps to bring output to a broader audience, not just academia. A lot of the time our research findings, except for when we do maybe policy briefs or community engagement, many of our research findings end up being for an academic audience. But when you have videos or you have images or paintings and so on, you can engage with the lay public, so to speak, as well. Now, despite these benefits or these advantages, there are some limitations to using visual methods. The first being that it is easy for some people to feel that they're not creative enough to be able to do these things, and therefore there's always a kind of either a resistance or a hesitation to engage or to participate in these kinds of visual activities. The idea that you have to be able to paint, artistically and properly, and having to be able to show people a creative side of you is sometimes difficult for some people to engage with. And secondly, the fact that, let's say, you're filming or you're photographing people definitely affects the way they behave in some ways, and so there's a certain obtrusiveness that exists when you're using visual methods that we have to be aware of, and you have to recognize that it's influencing the process, because the behavior of people when they're being observed may be different from what it typically would be. The other side of it is also that depending on the kind of interaction you build with people, the quality of the material or the quality of the outputs will be affected. And so if the participants and the researchers do not have that vibe, or they do not have that interaction that is appropriate for them to learn from each other, you may still come up with some materials or some information, but it won't be appropriate, it won't be the reality, because there's that connection is not quite there, and so it affects the quality of the material that may be provided or that may be produced at the end of the day. We cannot also overlook the idea of power relations. In a lot of contexts, when you're a researcher, you end up being the person in a position of power to a certain extent, when you're especially working in areas or in topics where the people are marginalized in some way, or they are of a perceived lower class or a different race and things like that. We have to remember those kinds of power dynamics and the fact that they may influence the visual research process. And then the fact that we have to constantly be reminded of the transparency of what we are doing. There's the real risk of us always having a sort of victimist gaze when we are looking at people, or we are interacting with people who are on the margins of society. We may be tempted, or we may inadvertently use their stories or their information in a way that suits what we understand or what we expect it to be like. And therefore, the images can end up being propaganda if we're not careful about how we structure it and how we approach the whole process. And of course, it can be very time consuming too. I mean, as opposed to doing an interview, for instance, where you set up time, you speak with a person for an hour or so. With visual methods, you have to build relationships, you have to understand what matters to the people in terms of how they will show their creative ideas and all of those things. It's a time consuming process that has to be carefully navigated. Right. So these are some of the brief things I could, a brief overview of visual methods more generally. But now I want to talk specifically about our project, the Together for Mental Health project, and how we made use of those kinds of visual aids or the visual methods, and in a way how we managed to, or how we attempted to navigate the limitations that existed, or that we were confronted with. So broadly speaking, our project was looking at understanding how mental health workers and traditional healers in Ghana and in Indonesia established relationships to prevent human rights abuses and to improve the care of people experiencing mental illness. And so this project, although it happened in Ghana and in Indonesia, what I'm presenting on today is specific to the Ghana data that we had. And so not much from Indonesia. The methods that we used were to look at an ethnographic documentary, creating an ethnographic documentary, and also ideally we had anticipated doing participatory videos with some of our participants in the field. Unfortunately, that has not happened yet because of COVID restrictions. I mean, literally the week that we were set to start the participatory video components, then coronavirus hit Ghana. So far we have not yet been able to do the participatory videos, but we do have a little bit of experience from our Indonesian colleagues about what they had achieved with that. Okay, now in terms of the reasons or the background behind our interest in looking at how the mental health workers and the healers were collaborating for mental health care in Ghana, one of the reasons is because of the change or the transformation of community mental health services in Ghana. There has been quite a bit of expansion of those services in the last few years, more concerted efforts to develop community-based care and integrate mental health into primary health care within the districts across the country. So several mental health nurses and community mental health officers have been trained and posted across the country to work in district hospitals and community health centers. And part of their mandate in these areas is to identify and form collaborations with healers, with the churches, the shrines, but also to look at partnerships with families and caregivers who to a large extent do determine a lot of the care pathways of their loved ones, and to engage with also community leaders and philanthropists in identifying ways to ensure that the kind of care that is provided is more appropriate. So in more recent years, that has gone on. There have been trainings on collaborations for the community mental health workers. So we wanted to see what it looked like now that they had been sent out there and expected to form these partnerships and work together. We wanted to understand what it looked like. So we used film as a method to understand or to try and identify what their collaboration processes were, how they built those partnerships, and what kinds of things facilitated those collaborations. So in terms of the field activities, we first of all set up an advisory committee to serve as some guidance. And this committee contained, stakeholders from across different criteria. We had people who were health workers, we had government agency representatives, we had people with a lived experience of mental health issues, we had caregivers, people from the media, even traditional healers. We had a couple of them also participating, and so this advisory committee really did set the tone in a lot of ways about what to look out for, where to go, how to do it, and things like that. And so I'll talk a little bit about each of these processes that happened in the field whilst we were doing this project. So as I said, we had our first advisory committee meeting before we went into the field. And again, we tried to use visual means to talk about what to do, where to film, whom we should look at or whom we should film. And so they gave us a lot of good guidance that sort of paved the way for us. They also talked to us about community engagement, all the way from community entry to understanding leadership, community leadership, philanthropists, and things like that. All of those things were discussed with the advisory committee from the beginning. So I thought I would show a little bit about the communities where we work. These are rural communities in Ghana, in the Brong Ahafo region, which is in the middle of the country. Since we did this, though, this filming was done in 2019, between April and June of 2019. Since we did that, there's been some restructuring of the region, so it's no longer called the Brong Ahafo region. It's been split up and things like that. But forgive me, I still tend to refer to it as the Brong Ahafo region in terms of this project. They are very much rural market towns. Most of the activities there are agricultural in nature. So they have these small community health centers that take care of the health needs of people, and mental health workers are part of these primary health centers, and they go into the communities to do outreach, to find healers, to partner with them, to do follow-up visits on former patients and things like that. So our data collection involved doing observations, but also doing interviews. We observed interactions between the healers and the health workers, the healers and the family members, and with the persons themselves. We looked at healing rituals that were done, and services, and festivals. So all of those things. We were able to film a lot of those kinds of interactions. But we also interviewed health workers and healers, caregivers. We did interviews with people with lived experience of mental health issues, as well as some local philanthropists who we were able to identify as some people who actually particularly were interested in mental health care, and therefore they provided additional services like employment opportunities. They sometimes intervened with traditional leaders and things like that. So we were able to also look at those kinds of interactions. So here are some of the pictures of some of the things that were going on that we're able to observe. On the left here is a healing ritual or ceremony that was going on at the time we were there, and we were also able to film the nurses going into the communities. In the middle there, they are doing some mental health education for people who were living at a prayer camp, at a faith healing center. They were resident there with their loved ones or with their caregivers, and so the nurses go in there to review them, to check on them, to make sure that they're being treated well and all. And whilst they're there, they do group activities for them, allow them to have some group sessions, and they take the opportunity to do some mental health education as well. Then on the right is a picture of one of the health workers looking at a register. The Mental Health Authority provided a register which all healers are required to keep, to take note of who comes there, where they're from, details about next of kin and all of that, so that the health workers can keep track of them as well. They can intervene when needed. And also sometimes people come from other communities to where the healing center is, and therefore the health workers can follow up with them after they leave to ensure that the care continues even when they are not in the healing center. So we're able to participate or to view as all of these interactions were going on with them. We also were able to interact, or to view as they interacted with the healers. On the left here, one of the nurses is talking to one of the healers about one of the people who had been brought there for care. Sometimes they have to discuss or to negotiate, some of the treatments that people receive, to encourage them to allow the nurses to provide psychotropic medication, even if the person remains in the camp and things like that. And as I said, we also interviewed some of the health workers. The lady in question, unfortunately, she passed on last year, but she was one of the pioneers of community mental health in that particular region. And so we interviewed her to understand her experiences and all of the things that she had done and set up or developed for that region. And then on the left, we're able to view when a new collaboration was being developed. The nurse had identified a new faith healing center that existed in one of the communities. And so we were able to go with him to see how he approached the collaboration. So here he is interacting with some of the patients who were living at the healing center and their caregivers as well, to understand what they were going through. He would do a brief assessment to see what kinds of medication they may need or what other services they may need. So we're able to view that as well. All right. So those were some of the activities that we did while we were there, and visual methods were very useful in helping us to understand what we were seeing. We're able to actually follow them around, observe, but also document what it was that their work entailed. How did they build these collaborations? What sustained it? What things facilitated it? Because there were some instances where these collaborations were not successful. So we were able to see what made the successful ones, but what were the challenges that they also encountered. So because we were filming, because we were using visual methods, we were able to see the kind of symbolic and embodied aspects of the interactions that they had. In this picture that I have here, the lady in question, the lady on the left, is a new nurse who was being introduced to one of the healers. The healer is sitting on the right. And from the way she's crouched over, you can see this deference to his authority. It's in traditional or in cultural understandings, this is how you greet somebody who is older or in a position of authority. You pay respect to them in a particular way. So we were able to capture those kinds of components of their interactions as well. And the fact that we were filming it we did not insist on English being spoken. It means people were able to interact as they normally would in the local languages. The methods of discussion did not have to be mediated by English or by written language for that matter, which sometimes can affect the translations. And so using visual methods was really helpful for us to actually see what happened on the ground. Some of the snippets of the film that we are developing has already started to be used for public engagement, and we envision that it can also be used for training. So having that actual film to see what it is like on the ground will be very useful in engaging people about what happens already, but what needs to change or what needs to improve as we go along. And in recent years, there has been quite a growth of, social media and digital methods of engagement or of advocacy, with social media champions or social media celebrities speaking up about their experiences with mental health issues here in Ghana as well. And so this is something that we are envisioning can be a good tool or a good way to discuss these issues of concern, because it's something that is already developing within the social media space. Right. Now, there were some challenges that were at that time important to note. It wasn't all rosy. We have to acknowledge those kinds of experiences as well. Obviously, the fact that we're filming, we are aware that to some extent some people's behavior may have been different from what it would be like if it was if we were not there or if we were not present. We do feel that as we spent quite some time with them, we had built previous relationships with many of the health workers over a number of years already. There was a certain level of familiarity with us already. So we do feel that some of the things that we were seeing were the reality on the ground. Now, we're also very much aware of our positionalities as researchers. We were a team of 4 women who were collecting data, all women, 2 of whom were white and 2 were black. But those of us who were Ghanaian, black women, we also had, to a certain extent, more education than, for instance, some of the healers or some of the participants that we engaged with. And so those kinds of power relations were very much present. It was something that we had to always carefully navigate, always be aware of, and find ways to navigate it so that it did not influence too much the process that we were hoping to observe. But also the issue of race, because 2 of our participants were white, it made the issue of the power dynamics, because we were in a post-colonial context, it was very much glaring. It went one of either ways. In some cases it was useful, but for some people too, there was quite a lot of distrust in what we were there to do, why we were interested in filming, because there have been experiences in the past with some people where people, as they say, outsiders come, take all sorts of sensationalist videos or pictures, and then next thing they know, they are all over the internet and things like that. And for a lot of people, that was embarrassing, or it was not something they wanted to be a part of. So we had to also very carefully navigate those kinds of legacies to continually reassure people about what it was going to be used for, how we were going to use it. Our consent process was staged and it was constant. We kept asking people to reconfirm what they were consenting to, and gave people opportunities to consent at different levels. If they wanted to be part of the filming in this way or in that way, they could indicate it. We also allowed them to choose how they wanted to be filmed, in terms of whether they wanted their filming to be done from behind so that they could not be recognized, or if they wanted to be filmed from maybe only shoulders and downwards, and all of those things. We had to carefully navigate it. It was also very much related to the stigma that there is around mental health issues in Ghana, or in many communities in Ghana. So even when people were able to consent, some of them were just too unwell at the camps, and so could not provide consent. But even those who were able to consent, some were not interested in participating, partly because of the stigma that is associated with mental health conditions. And then the big big challenge that we had to navigate was the issue of chaining or shackling of people and the human rights abuses. In a few of the places that we went to, we saw one or two people who had been shackled, and who were very much unwell. And so we witnessed the health workers' dilemma in having to find a way to navigate this issue of shackling, because the reality, as one of them told us, that there is not an alternative for them. They do not have the resources to take in people with mental health issues within some of the health units. The closest psychiatric unit was over an hour and a half or maybe even 2 hours from some communities, and it's a very small unit which could not take all of the people who need help. And so having to witness people shackling, knowing that it is wrong and it's illegal, but not having the ability to do something about it, for a lot of them was very difficult to navigate. And we did see that, we were able to see that, but it was also difficult for us as researchers, for us as wanting to be ethical, to see some of these things and then having to walk away, because we recognize the context within there. The way the health workers approach this is to negotiate with the healers and the family members and start to offer to start treatment and all of that, so that they can show that the shackling is not necessary anymore. So we had to respect those processes, not to rock the boat for them, because after our project, we were not going to be there anymore. So we recognized this dilemma and we felt it ourselves in a lot of ways. So those are some of the things that were difficult to have to see. And then lastly, what we've used our footage for. So far, we haven't released the final films yet. That should be happening in another month or so. So I hope that I'll see some of you there. But we have released some excerpts, and we have started some engagements with the information that we have, or the footage that we have. So we started to try and do some level of advocacy already. The usefulness for this is that it shows the reality of what is going on the ground, and making the people the invisible things visible. Some of the health workers that we worked with said that they finally feel like they're being seen, that their efforts are being appreciated, that people are starting to recognize what they have to go through to do the community mental health work that they are mandated to. There's so much passion to do the work, but it's really difficult because of limited resources, limited support from the larger authorities. And then for these kinds of interactions that we had with them, finally made their work visible, finally started a discussion going. And so it was useful for them, or they found it useful to be part of this project. We started engaging on radio stations and other kinds of social media and engagement to do some awareness raising, not just about mental health issue, but about what collaboration looked like, what kind of help was available. We went with one of the nurses to a radio station for him to tell people that there were options there for them within the public health system. They were willing to work together with them. They did not want it to appear that they were just there to condemn all traditional healing, but they wanted to work with them. And so they had started to do a lot of awareness raising, which our presence and our involvement also helped to facilitate, to educate people, to inform them, and to empower them to actually take steps to allow the collaboration or the collaborative care to be an option for them. Definitely breaking the chains was also one of the key things that we were interested in seeing, and some of the health workers that we worked with told us about experiences where they had started to work more with healers, they had started to release more people from the chains, and treatment was being given within these places more in some situations. And then social interventions, we had been able to support the picture on the left here is a young girl whom one of the mental health teams was looking after. They were treating her out of their own pockets. They were paying for her treatment, and they had started to support her to start a little business because she did not have family support. And so we went with them to see the social welfare services to try and get her on some benefits, some welfare support. We were also able to engage with them to provide some assistance in terms of her starting up her little business. She sells candy and biscuits and things like that, just as a way to be able to survive. Unfortunately, the social services at the end they chose not to support her for whatever reasons, but we were able to support her in a little bit so she could start to actually work at making her own income. So these were some of the ways that we've used so far our work. These are some of the ways we're engaging with our information. And there are ways that visual research can powerfully show people what can be done, what is happening, what needs to change, what can be done appropriately. So this was very useful for us to do. All right, so that is that for me. I want to say a big thank you to the teams, that Together for Mental Health team and our participants. It's been an incredible journey, a 2-year journey that has led to so much learning, so much engagement, so much awareness for us as researchers as well. And my thanks to Professor Emilia Colucci. She gave some guidance with the visual materials and all of that. So if you're interested in more information about the project, please visit the movement.org website, movement.org. You'll find Together for Mental Health as one of the pages on this website. And we are on all the social media platforms as well. If you want updates, please follow us to see when we are releasing the film and other engagement activities that we'll be doing in the future. Please make it a point to join us as much as you're able to. Thank you so much. And if you have any questions, I can take them now.
Wow, Lily, thank you so much for sharing that with us. It's Bronwyn again.
Yes.
That was that was really incredible. Sort of giving us a little bit of a background on visual methods and some of the limitations, but then also how you're currently applying it to this work on sort of what mental health collaboration entails and the various stakeholders and the journey. And it's wonderful that you're able to also share it with everyone through this movement initiative. So thank you so much for that. I see we have a hand from Leslie. Leslie, please go ahead.
Thank you. Thanks, Lily. Great to hear your talk. Lily, I wonder if you can, I do have some knowledge of this project, as you know. And I wonder if you could talk a little bit about the sort of ethical dilemmas on the one hand of the right for people to be represented and to participate on the one hand, and on the other hand, the problem of representation and the vulnerability of people, and how you negotiated your way between those two.
Okay.
I think it's really interesting.
Okay. All right. Thanks, Leslie. Yes, you're absolutely right. People do have that right to be represented, and we had to actually we did have lots of discussions on this issue of capacity to consent, but also how do you show people if they want to participate, how do you include them without assuming that vulnerability, without excluding them because you think they're not well enough. It did present a lot of ethical difficulties, which we had to think through. We had a steering committee in place, which was very, very helpful in terms of guiding us to think through how we navigate some of these issues. But we had to then also on the ground think about who do we approach to, who do we speak to, in order to be able to identify who is willing to participate, who can participate, but who should be shown and in what ways. I think as much as possible, the way we had developed the consent process meant that we were constantly engaging with our participants. We were constantly asking questions about, what they wanted to do, how they wanted it to be done, to what extent they want to be a part of things. We had to rely on our instincts for one, on our training, but also on the healers and the health workers who have worked with some of these people, and also on the people themselves, those who said they wanted to be part of it. We had to respect that. We had to respect that and include them, and in the ways in which they felt comfortable being included. But yes, it's a good point. There's all sorts of things to think about in terms of the ethics of inclusion, because you do not want to exclude people when you presume that they'll be vulnerable. There were all these issues also about showing people in a certain light because of stigma, wanting being careful about how we develop the film so that it does not cause further stigma within small communities where they may be known, or where there may be backlash to them or their families. And so it all involved, the consent process involved all of those kinds of questions and discussions about what it would mean to be a part of something like this, what could be the potential outcome, what do you think people would think about you if you were part of all of those things were questions we had to ask them. I don't know whether that answers your question.
Thanks very much. Thank you.
Thank you, Lily. Any other comments or questions from the audience, the virtual audience? If there aren't any, Lily, I've wondered sort of what has been the feedback from the broader community about this work. So you've done sort of radio talks and various other types of dissemination activities. What has been the feedback from the broader community?
Okay. All right. So generally, people have been very interested in the work and in the outputs that we have so far. As I said, we have a few short clips already, an excerpt of the bigger one, but the full film has not yet come out. We do plan on engaging the communities, in a more in-depth way once the videos have been released. That's our next step, so to speak. So we plan to do community screenings, to hold discussions about what we are seeing in the film, what it means, what it could be used for, and all of that. So we haven't quite done that yet. But from the online work, the radio work that we did, people are very interested. People in other parts of the country, for instance, community mental health nurses in other parts of the country. I've had a few people telling me, you should come here and see what we are doing. As I said, they finally feel like they're being seen. Community mental health work has been going on for some time in the country, but it wasn't very formalized until quite recently, when it was more properly structured and developed, and people have been doing things. So they finally feel like we're seeing them. We're seeing the work that they're doing. We're seeing the ways in which they are struggling with the limited resources, because there isn't much of a budget for mental health in the country still, despite the fact that it's better. It's still nowhere near enough. And yet they're finding innovative ways to provide care and interventions for the people under their jurisdictions. So the reception has been good so far. We've got a lot of interest from outside of Ghana as well. A few people from like Cameroon and even Nigeria and stuff who say, it's similar to what they've experienced, and so it gives them a lot to think about, and even to want to put in place, so that for those places where collaboration is not quite ideal, they can start to think of these kinds of things as well. So far so good.
Sure, that's wonderful to hear. So you haven't had much backlash from the community, or
No.
any sort of overt issues around stigma and exposure, and nothing.
No.
No,
So
that's
far,
awesome.
no. But as I said, the full film is not yet out, and we haven't gone into communities to do screenings, to hold actual discussions yet. And so perhaps the people we are hearing from are those who would be exposed to social media, or these kinds of platforms already, which is a different class of people than, let's say, some communities across the country. So it may be different when we start to go into the communities for these screenings, but so far we've been lucky.
That's wonderful. Well, Lily, that's all the questions that I have for you. I'll ask the audience once more if anybody has a comment or a question for Lily this afternoon. Yes, Leslie.
I don't know if am I allowed to talk again, Bronwyn?
Of course.
I just, no, I mean, just one thing that I think that really, struck me. It wasn't for this project, but on one of my trips to Ghana was this issue of chaining that you've mentioned, Lily. And you did speak about it briefly in your talk. I mean, from the outside, and certainly in a lot of the sort of dominant literature coming from the global north, it's just seen as a sort of terrible human rights abuse. I'm not saying it's not a human rights abuse, but one of the things that I realized when I visited Ghana was I didn't understand the context of chaining at all. And I mean, maybe just for the audience of South Africans here, can you just talk a little bit about why are people chained up, and
Okay.
what is the context, and is it all, are there reasons why, or was it just abuse?
Okay. All right. Great. Thanks for that, Leslie. Yeah. From what we saw, now of course, let me preamble this by saying that we went into communities where there is an established community mental health presence, and so that definitely also affected what we saw. But from my experience here and in a few other communities, chaining was usually done as a way, and absolutely, like Leslie said, we're not saying it is right, we're not encouraging its use, but a lot of the time there were no alternatives. When people were severely mentally ill, they were aggressive, they were disruptive or disordered, they were sometimes threatening the people that they lived with. Chaining was done as a way to control that, to restrain them. It is not as a punishment most of the time. It is not as a punishment. It's because they feel there is no other alternative. There was one father who spoke to us who said that his son, when he first started to get ill, he had been to different hospitals, psychiatric hospitals. He had been to different healers. He had been all over, and they just couldn't help his son. And when he comes home, he doesn't sleep. The son is walking all around, he's disrupting things, he's yelling and shouting, he's breaking people's property, he's damaging things. And the father just could not handle it. And this is an old man, a very old man who was a single father at the time. So it was just the two of them. He said there was nothing else he could do. So he found shackles and restrained his son in that way until the nurse, the community mental health nurse, showed up in their house one day because he had heard that somebody had been chained and started treating him with a different kind of medication. And the chains came off. So for a lot of people, it's because there's no alternative. It is not to punish them. They feel that their loved one is a danger to themselves or to other people, and they need to restrain them. Our health systems are not able to support many of these rural communities with other options. There are no options for them. There are no mental health units. Until recently, as I said, there were not any formal community mental health services until 2012 when we started to more seriously look at these things. So for people, the chaining is a way to restrain. So another example is from one of our researchers, Ursula Reed, who has worked in those communities for over a decade. While we're there, I think she met a former participant of hers when she was doing ethnographic work for her PhD, who was a caregiver to a young man who had a severe mental illness at the time. No, sorry, she met his father and asked about the mother, who was the primary caregiver, and she has said that she was told that the boy had stabbed his mother to death the year before. Now, that's not to say that all people with mental health issues are disordered, or they are aggressive, or they would kill you. But for many people, it's a real fear, a real danger that they feel then leaves them no option but to restrain the person, because medications they've tried have failed. people who say they would heal them in one way or the other have not been able to do that. So it talks to the real deficiencies we have within the psychiatric services here in the country, maybe elsewhere, but also the lack of resources and political will to actually ensure that services are improved and services are beefed up so that people have options beyond using mechanical restraints. So it's usually not a punishment. It is most of the time an act of the only option they think they have. Yeah.
Thanks, Lily. Thanks very much. So, if nobody else has any other comments or questions, then I would like to thank Lily very much for your time this afternoon, and for sharing this journey with us. And the end bit of the conversation now, I think, is probably a lot more difficult to talk to, and as you try to contextualize that for others. But thanks very much. It's important, and we appreciate it. And thank you everyone for being here this afternoon. And Lily, we hope to see you soon in person again.
Yes, definitely.
And all the best with the rest of this project and this very important work.
Thank you very much. It's been a real pleasure being here with you.
Thanks so much. Colleagues, please join us again on the 14th of June for a presentation by Dr. Dorian Boyson, where he will be talking about the feasibility of disseminating and implementing therapy for survivors of trauma in South Africa. So we'll see you all then again online on the 14th of June. And Lily, I hope you'll join as well.
I will do my best to, yes. Thank you, Audrey.
Awesome. All right. Thanks, everyone, and have a wonderful afternoon further.
All right, then. Thanks, you too. Bye-bye.
Bye.